Hello everyone, I hope all are fine. Actually, the most common questions have been asked to you once you graduated from Faculty of Pharmacy. What do you think about this medication? If you are a pharmacist, a clinical pharmacist, in a clinical round, in a hospital, in between multidisciplinary team, any one of other medical staff can ask you, Doctor, what do you think about the treatment plan of this patient? What would be your answer? The other scenario, you are a pharmacist in a retail pharmacy, community pharmacy, and someone, patient, came to you with a prescription from a physician and asked you about the medication which is written in this prescription. Third scenario, between your family, one of your relatives asked you, today the physician prescribed for me one medication. What do you think about this medication? These three scenarios, before you answer, you need to think what they are asking about. What they ask about. They ask about indication or ask about safety of the medication or side effect or contraindication or drug interaction. They ask about what? The answer in this lecture in one slide, if you memorize, you will give a professional answer. Even if this question has been asked to you in an interview when you want to apply for a job as a pharmacist, as a professional pharmacist, you need to answer professionally on this question. If the interviewer asked you, what do you think about this medication? He gave you scenario for one patient. He has a condition and he take a medication. How you evaluate this medication as a pharmacist? What will be your decision? Either to continue or modify or stop based on what? This is our lecture today. How to evaluate a patient medication therapy plan as a clinical pharmacist approach. When you end this presentation, student will be able to apply simple 5-step framework to critically evaluate appropriateness of a patient medication regimen. First of all, let me introduce myself. This is Dr. Ahmed Sabri, clinical pharmacist, board certified, working as a clinical pharmacist in Al-Qasim Women and Children Hospital in Sharjah, United Arab Emirates. Today we will go in a journey started from prescription to the patient, and we will know the art of reading clinical cases. Before we start, we need to know who we are. The pharmacist, our role not only to dispensing medication, not only to dispense medication, but to know the story behind each medication. Because each medication has a group of information you are as a professional pharmacist. You must know and collect all points to draw the final picture. And to go in deep in this and to think in this meaning, we need to know some basic things. What's the difference between clinical pharmacist and dispensing pharmacist? This is based on our knowledge about the difference between clinical pharmacology and normal pharmacology. Actually, in ancient times, the term of clinical pharmacology wasn't exist. Only the science of studying the medication is called pharmacology. Pharmacology was the scientific study of the effect of drugs and chemicals on living organisms, where a drug can be broadly defined as any chemical substance, natural or synthetic, which affect a biological system. You can say briefly that pharmacology it was the theoretical study of the effect of medication in a living organism. But clinical pharmacology this is advanced meaning after the world realized the importance of studying the real effect of the medication on the human. After that, they focus on clinical pharmacology to be the science which, based on it, they will build the clinical pharmacy structure. If we want to give a clear example in this, for the heart failure patient, the backbone of the medication for this kind of disease is called beta blocker. Beta blocker, something used in heart failure patient to reduce the overload of the heart and to increase the life quality and to reduce mortality. But in heart failure, according to the trials which has been done, they found that only three beta blocker which is can be effective in heart failure patient: metoprolol, bisoprolol, carvedilol. All other beta blockers are not used in heart failure. This is a clear example to differentiate between pharmacology as a science and the clinical pharmacology as a real. To answer our question, we need to memorize one sentence. I safe. I safe is abbreviation to be easily memorized, to can catch all points and collect it in your mind before answer this question, to perform a professional answer as a professional pharmacist. Indication, safety, adherence, follow up, efficacy. When you answer, you need to cover all these 5 points to give a clear, complete image for the one who asked you. iSafe is the system you are using to collect all the needed information about the medication which you have been asked about. because you are, as a clinical pharmacist, your role to move beyond the simple drug knowledge to evaluating the entire treatment plan within the context of the whole patient. Our primary goal is to systematically identify and resolve drug-related problems using a standard framework. What is the structure of iSafe? First indication. In this indication, you need to know 4 points. Do I have drug without indication, or indication without drug, or therapeutic duplication? And is my medication follow the latest guideline alignment? After indication, safety, it is a main concern. Is medication is safe? Any contraindication or interaction? I need those adjustment because he's old age, or he has renal or hepatic function impairment, or I need to do needed monitor parameters. After safety, I need to confirm my patient will take this medication regularly on time, or there is some barriers prevent him from follow up the treatment plan. Does the patient understand the instruction? After this, he started the medication. Do I need to do any follow up or monitoring to confirm the safety of my patient from the side effect of the medication? And last point, my patient, he follow up already. We follow up the medication plan. Is it effective for him, or still I need to modify or stop it and start a new medication? So when I face this question, what do you think about this medication? I will memorize I safe, indication, safety, adherence, monitoring and follow up, and last, efficacy. We will talk about our first point, indication. The first thing I need to check up when I evaluate either one medication or treatment plan completely for one patient, I need to check first the indication. What does it mean? I need to know that this is the right drug for the right problem. First point, evaluating why each medication is prescribed, ensuring there is a valid evidence-based clinical reason for every drug on a patient list. Is there a clear indication for each drug? For example, Patient is taking omeprazole 40 milligram daily, but I didn't find any diagnosis of GERD or PUD or history of non-steroidal anti-inflammatory disease drugs or even steroid use. My intervention as a pharmacist to stop it because this a drug without indication and I have a risk of side effect of hypomagnesemia or C. difficile infection. Second point, are there is missing indication? This patient is asking me about this medication, but while talking with the patient, maybe I will discover that there is a problem the prescriber didn't notice. Need to make an intervention here and point that I have indication without medication. Example, patient with heart failure, reduced ejection fraction, not receiving ACE inhibitor or ARBs or anti-ARNI or beta blocker. And as we know, these agents improve survival and reduce hospitalization and slow disease progression, which means reduce the mortality. So removing one of these medication will it's have a high risk for the patient to increase the mortality rate. Third point, I need to confirm, are there any duplicate therapy, two drug treating the same condition unnecessary? For example, patient received ibuprofen and diclofenac as a painkiller. I need to stop one of them because high risk of GI bleeding or renal injury. The last point, is a drug the best choice for that indication? Is it follow the latest guideline support? For example, I need to check if it is the first line or second line or this medication of label use. Patient 45 years old and he has type 2 diabetes. Doctor prescribed for him Glimepiride as diabetic medication. But Glimepiride, it is not the first line for type 2 diabetes. Must the prescription must contain metformin according to American Diabetes Association. Second point, safety. Is my medication safe for this patient? Maybe one medication which is correct or right or safe for one patient, it can harm another. So I need to confirm right drug, right dose, and right patient to protect the patient by ensuring every drug is used safely. First point, what is safe for one patient may harm another. How? Check if my patient has any particular condition or disease prevent him to take this medication, which is called contraindication for taking medication. For example, review allergy, age, pregnancy, and renal and hepatic function. Watch for disease-related risk. For example, I can't use non-steroidal anti-inflammatory drugs as a painkiller In chronic kidney disease patient, I can't use beta blocker for hypertension. In patient with asthma, the right drug in the wrong dose becomes the wrong drug. The dose, it has a range, so I need to specify, is my patient from pediatric, from adult, and what is the correct dose for him? Because if I give overdose, I will expose him to toxicity. If I give underdose, I will expose him to medication failure. Check the dose, route, and the duration. And actually, the number of errors at this point from a physician prescriber are many. And also, if the patient is renal or hepatic impairment, so I need to adjust the dose as the renal adjusted dose or hepatic adjusted dose. And also the duration. Each medication should be taken for specific duration of time according to guideline, except in a chronic disease, which they are taking chronic medication forever. They are exceptional. But most of medication are used for limited time only. So giving the medication for longer duration expose the patient for unneeded side effects like proton pump inhibitor and antibiotic. Third point, check before you mix, monitor before you risk. Is my medication can interact or cause toxicity? Check for interaction and the monitoring needed. Interaction has three types: drug-drug interaction, or drug-food interaction, or drug-lab interaction. And also I need to set up monitoring. If I taking warfarin, for example, I need to check INR. If I taking ACE inhibitor or spironolactone, I need to check potassium level. Third point, adherence. Does my patient follow the rule as it is written for him? Because the best medicine works only if it is taken on a proper dose, on a proper time. If the plan is too hard to follow, it is easy to fail. So, can the patient realistically take this medication as prescribed? So we need to know the social difference between every patient and another, because the forgetfulness or complex regimen or lack of understanding, all these barriers prevent the patient from follow up and taking the medication properly. So it will affect my adherence, and of course it will affect the outcome. So simplify schedules, one of the recommended advice at this point. The medication which I can given once daily, easy to follow, than the medication which is taking more than this. Second point, a therapy the patient can't afford is a therapy they can't follow, because what might stop the patient from taking medication? From cost, unavailability, or unpleasant side effects, lower adherence. Especially in pediatrics, there is some medication which has bitter taste. So the guideline advise to mix this medication with some kind of juices which will not affect its bioavailability or efficacy. It will be easy for parents to give their child the medication regularly. Discuss affordable or better tolerated alternative if there are. Educate once, follow up twice. That's adherence for life. Does the patient understand why and how to take the medicine? Are you sure from this? Provide clear counseling, written instruction, and follow-up checks. Encourage feedback and adjust the plan when needed. At this point, we will use technique called teach me back. I will allow the patient to explain for me what is written for him to be sure that he understands completely the instruction clearly. Fourth point, my patient started the medication already, but do I need to do any monitoring to check the side effect of the medication or to modify doses, duration, frequency? At this point, we will talk about follow-up and monitoring. What gets monitored gets improved. The something which I can monitor, I can easily improve. So define what to monitor and when. No monitoring, so no control. Follow the data, not the guess. How will we know if the medication is working and is still safe? Identify key clinical and laboratory parameters for each drug. Set a specific time frame for reassessment. So any drug the medication is taking, I need to know how to monitor this drug and when. For example, patient taking medication for hypertensive, I need to monitor blood pressure or diabetes medication. Chronic diabetic medication, I need to follow or monitor HbA1c every 3 months or something affect kidney. So I need to monitor renal function after 1 to 2 weeks. Patient, for example, on ACE inhibitor lisinopril for hypertension. What I need to monitor? I need to monitor serum creatinine and potassium after 1 2 weeks. Then if he's stable, it will be periodically. Why? Because this kind of medication can cause renal impairment. So if I detect early renal impairment or hyperkalemia, I will reduce the dose. Second point, reassess therapy and adjust accordingly. Monitor, modify, and move on. Every plan must evolve with the patient. I need to ask the patient improve or experience problems. For example, compare actual outcome with target goals. I give hypertensive patient a medication to lower his blood pressure. So my target of blood pressure is less than 130/80. Or dyslipidemia patient, my LDL should be less than 70. So I will modify those or add or discontinue medication based on response and safety. Document, document every change clearly with rationale. For example, patient on warfarin for deep vein thrombosis. I need to monitor INR every few days until stable, then monthly. Because if INR more than 3, I need to reduce the dose or hold one dose and recheck. Or if it is less than 2, the risk of thrombosis is high, so increase dose cautiously. My last point, efficacy. My patient took the medication for specific period of time, and during this period I follow up and monitored. But I need to know after the end of this period Was my medication the best choice for this patient condition or no? So I need to achieve my goal as efficacy. First point, evaluate the therapeutic response. If you can't measure it, you can't call it effective. Is the medication working as intended? Check clinical outcome, symptom control, improvement in disease markers, review laboratory result or vital signs relevant to the drug purpose, or compare result with the target goals set by guideline. Optimize therapy when goals are not met. If I continued my medication and there is no benefit from it, so it is not logic to continue on it. I have to modify or discontinue and start a new plan. If the drug isn't effective, what should it change? The dose, the drug, or the approach? Verify adherence and correct administration first, or escalate dose, switch to another class, or add synergistic therapy based on evidence. Always re-evaluate after each adjustment. For example, I have type 2 diabetic patient on metformin 1000 BID and HbA1c 8.9. My goal less than 7%. So after confirming the adherence to medication and diet control, I can decide that metformin alone is insufficient, even if there is no symptoms, because I have a target in diabetic patients, and my target will decrease the mortality rate and decrease the morbidity and increase the quality of life. So according to American Diabetes Association, I need to add to metformin SGLT2 inhibitor like empagliflozin. Someone can ask, what is the difference between monitoring and efficacy? Both of them, I need to take lab result after taking the medication. Actually, monitoring and efficacy, there is slight difference between them. These points will clear what is the difference between monitoring the medication or checking the efficacy. First question, is the therapy safe and under control? If this is my question, then I'm checking monitoring. Is the therapy actually working and achieving goals? Then I talk about efficacy. What I need, what I will focus on. Early detection of problems or toxicity during treatment, then I'm talking about monitoring. Measuring therapeutic outcome and clinical improvement, then this is efficacy. What's my purpose? To prevent harm and detect adverse effect early, then this is monitoring and follow-up. Or to confirm benefit and optimize results, so this is efficacy. And also, they are different timing. Continuous process, this is monitoring. Start immediately after initiating therapy. Or if I will evaluate after enough time has passed for the drug to show effect, this is efficacy. Example of parameters like renal function for ACE inhibitor, as this is called the monitoring, but HbA1c for diabetic control, this is called efficacy. So my type of question, is this drug still safe to continue? Then I may talk about monitoring. Or is this drug still worth continuing? This is efficacy. If we took this example and to see how for one drug I will do monitoring and efficacy checking. 60-year-old patient on enalapril 10 milligram daily for heart failure. So what I need to monitor after 1-2 weeks, I need to check serum creatinine because lisinopril from ACE inhibitor, it will affect kidney, and potassium to ensure kidney function is stable and no hyperkalemia. This is monitoring. But my goal from checking efficacy that after 3 months I will check symptoms like dyspnea, edema, and ejection fraction to see if the heart failure improved or not. So phrase to remember: monitoring, early warning, safety watch, efficacy, final result, goal, achievements. By the end of our lecture, I appreciate everyone completed the lecture till the end, and I hope it added to his or her knowledge something beneficial. My last advice for you as a professional pharmacist: don't treat the medication as something you are just sell it to the patient or take it from the shelf to give it to the hand of the patient. The medication is a story, and you are the only one who able to read this story. It's a map, and you are the only one who has the key to discover this map. No one except you is a drug expert, and no one except you is a know the secret of the drug. Thank you for your listening and hope to see you again in upcoming lecture.